Greetings again, everybody. We are going to continue our survey on infectious diseases that occur during pregnancy, here talking about urinary tract infections. Now, when we think of urinary tract infections in general, we often revert to just thinking about acute cystitis, the bladder infection, which is ubiquitous. Especially if you're working down in the ER, you're going to see bladder infections all the time. A lot of women are just predisposed to getting bladder infections. When we think of UTIs in pregnancy, however, we need to broaden our scope because there is one particular UTI that is more common in pregnancy, acute pyelonephritis, which has tons of important implications for the pregnancy, really problematic implications. And then there's another thing that is asymptomatic called asymptomatic bacteriuria, which we would not detect unless we do a screening test because it is asymptomatic. And we know that women who have asymptomatic bacteriuria will go on, many of them will go on to develop some of these more problematic UTIs, bladder infections and pyelonephritis. And so here we're going to talk about the management of these things as well as how and why we screen women and when it's appropriate to screen women for asymptomatic bacteriuria. So that will be the topic of our discussion here. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of the video, and that should link you up. If you could just consider chipping in $1 a month, a little bit goes a long ways to help keep these videos free. If you contribute, you will have access to some of my premium videos, which are case reviews, and that would be very helpful to you, especially if you're taking step 2 or step 3. On step 3, you get those clinical case scenarios, and I do go over sort of the workup and kind of a tailored, focused diagnosis and treatment plan and how you can strategize coming up with those things because that's going to be very important, especially for step 3. All right, so this is our sort of list of infectious disorders of pregnancy. Of course, you can get all sorts of infections, but these are divided up into the infections that the complications increase in pregnancy. Of course, UTIs are going to be part of that because of the potential of that leading to pyelonephritis. And pyelonephritis is actually more common in pregnancy. And the complications of pyelonephritis are very, very problematic. All right, so we're going to talk about UTIs and pyelonephritis. Pyelonephritis, of course, being a UTI. All right, so what is a UTI? What's it caused by? Well, it's caused by an ascending infection, and that infection it comes from bacteria usually in the rectum, in that area. What's the most common cause of a UTI? The most common cause of a UTI bacteria is E. coli, Escherichia coli. It makes up about 80 to 90% of UTIs. Some of the other common causes are Klebsiella pneumoniae, Proteus mirabilis. Those are really the big three, but E. coli is the #1 cause, and of course that is ubiquitous in the fecal flora. And so this is typically where it's coming from. So it's an ascending infection. The risk of UTI is going to increase during pregnancy, and there are 2 big reasons for that. First, you have urinary stasis. So why do we get urinary stasis in pregnancy? Well, first of all, you have a gravid uterus. That's going to place pressure on the bladder, make it a little bit more difficult to void. The other problem is that you have elevated progesterone, and progesterone will relax the smooth muscle, and that includes smooth muscle in the bladder. The bladder has lots of smooth muscle in it. So you put those 2 things together and you get urinary stasis. We also know there's a certain degree of glycosuria, and what does bacteria like to eat? It likes to eat glucose. So if there's more glucose in the urine, bacteria are going to proliferate. And so those 2 things together raise the risk of UTI in pregnancy. UTI is associated with adverse fetal effects. And so in particular, we want to watch out for the asymptomatic bacteriuria. So the biggest risk factor for the development of a symptomatic urinary tract infection is the existence of asymptomatic bacteriuria. It confers a 20 to 30 time increased risk. So that is why we screen for asymptomatic bacteriuria, and we're going to do that screening at the first prenatal visit, and then we'll also screen again for asymptomatic bacteriuria at the third trimester visit, somewhere around 26 to 30 weeks. So this is good information to tell any woman, pregnant or not, because of course women are at a significantly increased risk for UTIs relative to men, about 14 times increased risk of UTI compared to men. And so some of the things that they can do to prevent a urinary tract infection are to, avoid bathing. Of course, a lot of women are going to want to bath, but if a woman gets UTIs often, it may be advisable for her to try to limit the amount that she bathes and to maybe shower instead, because of course if she bathes, her urethra, the urethral meatus, is going to be submerged in water. And what also is in that water? Well, her anus is in the water, and a little bit of fecal flora can get into that water, and then that water can get into the urethra, and that can cause an infection. Another thing, of course, wash hands before using the toilet. A lot of us don't think of that. We think of washing hands afterwards, but if you have dirty hands and then those hands go anywhere around the urethra, you can contaminate it that way. Another very obvious thing, but something that a lot of people don't think of, is to wipe front to back. So if you're wiping back to front when you're wiping, you're going to drag fecal flora up to the urethra. If you wipe front to back, you will drag all of that away from the urethra. So it's best to wipe front to back. Using liquid soap. So the soap that you use in the shower or in the bathtub typically is not antibacterial soap. It's just soap designed to get oils off. And so bacteria can grow on bar soap. And so liquid soap is actually a little bit better because it's in a container and it's less likely to have bacteria growing around in it. And then clean the urethral meatus area first so that you're not touching the urethral meatus after you've touched other areas. Okay, so these are good tips to give any woman, especially women who get UTIs frequently. It's also very good to give tips to give women in pregnancy as well. So we're going to talk about three things: asymptomatic bacteriuria, acute cystitis, and pyelonephritis. And the one thing I want to point out here is that the urine culture, if you were to get it in any of these women with any of these three things, it's going to be positive. Of course, with asymptomatic bacteriuria, are they going to have urgency, frequency, burning? Are they going to have fever? Are they going to have CVA tenderness? No, it's asymptomatic. So only the urine culture will be positive, everything else will be negative. So when you're getting that screening test, it'll be a surprise to her because she doesn't have any symptoms, but the urine culture comes back positive. Okay, so that is asymptomatic bacteriuria. Acute cystitis, pyelonephritis, the urine culture symptom profile is the exact same as what we would expect in a non-pregnant person who comes in presenting with this. So you don't really have anything to memorize with this. Now, are women asymptomatically bacteriuric outside of pregnancy? Of course. But we're not worried about it then because we're not worried about a pregnancy when she's not pregnant. And asymptomatic bacteriuria confers risk on a pregnancy. It doesn't really confer risk on a woman who is not pregnant. So that's why we're concerned about this during pregnancy. But certainly a woman can have asymptomatic bacteriuria outside of pregnancy. So asymptomatic bacteriuria, or also abbreviated as ASB, all women are screened for bacteriuria at their first prenatal visit, and about 10% of women will have a positive culture. And we will treat all of those women because we want to eradicate that bacteria to reduce their risk of developing pyelonephritis. Risk factors for asymptomatic bacteriuria include a lower socioeconomic status, diabetes, a history of UTI. Women who get UTIs more frequently are more likely to have bacteria in their bladder. Multiparity, anatomic or functional urinary tract anomalies, and sickle cell trait. About 30 to 50% of women with asymptomatic bacteriuria will develop symptomatic UTI if not treated. And that is why we do this screening, because that's a lot of women. Okay, if we don't screen women for ASB, 10% of those women will have a 30 to 50% chance of going on to developing either acute cystitis or pyelonephritis. And what I've read in the literature is 30% will develop pyelonephritis. So you're talking 3% of all pregnant women we are saving from going on to develop pyelonephritis just by doing the screening and giving treatment if they come back positive. That's a lot of women that we're preventing some really serious problems in. The symptoms, of course, there aren't any. It's asymptomatic. Physical exam will be unremarkable. Diagnosis is simply a positive culture, and usually that will grow E. coli. The treatment for asymptomatic bacteriuria, there are multiple antibiotic regimens that you can give. Most commonly, we give nitrofurantoin, and that's also known as macrobid. You'll give 100 milligrams twice a day, 7 to 10 days, and then you'll repeat the culture after treatment, and then you'll repeat it every month thereafter. Now, most of the time, you give the nitrofurantoin, you repeat the culture, and it comes back negative. You're still going to check it every month, get a urinalysis, or you just get a urine culture. But if you happen to not eradicate it, so if you have, so what you're going to do is you're going to give the medication, you'll take another culture. If the culture comes back positive, you'll give another course of antibiotic. If it comes back positive again, so a third time, then you're going to do daily suppression therapy. So she's going to take antibiotics every day for the rest of the pregnancy. And that can be either macrobid or cephalexin. Okay, that's called daily suppression therapy. And we will give that to women who have 3 positive cultures for asymptomatic bacteriuria, despite having given 2 courses of antibiotic. Okay. So acute cystitis is a bladder infection, and of course this is going to be symptomatic. So what are the symptoms of bladder infection? Well, pain on urination, a sensation of incomplete voiding. This is a very, very specific symptom for a bladder infection. Urinary urgency, so they feel like they need to go. Frequency, they need to go often. Suprapubic discomfort. Physical exam, you may note some tenderness on pelvic exam with manipulation of the bladder. So when you put some anterior pressure, when you're doing the pelvic exam, you may elicit some tenderness that way. What you're not going to see is CVA tenderness because this is not affecting the kidney. Diagnosis is urinalysis and culture. The urinalysis should show you positive nitrites and esterase, increased white blood cells and red blood cells. Because of the infection in the bladder, proteinuria may be present. There may or may not be bacteria that can be appreciated, but the nitrites and esterases are going to be what really will tip you off for acute cystitis. Just like diagnosing acute cystitis in anybody else. There's really no difference here. And then the positive culture is the most specific or the most accurate test. But typically that takes a few days for it to come back. But if you have a patient who comes back on their urinalysis, they've got all the symptoms, or many of the symptoms, and they have positive nitrites and white blood cells, you got your diagnosis there. The treatment for acute cystitis in pregnancy is the same as what we do for asymptomatic bacteriuria. So you give nitrofurantoin. Other treatments that you can give, and this goes for asymptomatic bacteriuria and cystitis, you can give ampicillin, you can give augmentin, you can give cephalexin, you can give fosfomycin, but I would say that nitrofurantoin is the most common treatment that's given. You won't be asked to choose between those on the test. Nitrofurantoin, though, in the exam questions that I've seen in test question banks, that's the one that comes up most often, in my opinion, from my experience. So the same, you're going to go about this very similarly to how you go about asymptomatic bacteriuria. So you will give the treatment, and then you'll repeat the culture after treatment. If the woman develops another UTI, then you're going to give daily suppression. Okay, so if she gets 2 UTIs, she's going to get treatment, and then after that, she is going to take an antibiotic every day through the rest of the pregnancy. Now, some women you may consider giving daily suppression therapy even if they just have 1 UTI, and that would be, for instance, women with diabetes or women with sickle cell trait, because we know that they're at an increased risk for developing UTI to begin with, and so why wait for them to develop a second UTI when they're at such high risk? That's the thought behind it. But for most women, if they develop 2 UTIs during pregnancy, after that second UTI, you're going to give treatment and then daily suppression therapy. And the treatment is nitrofurantoin. Okay, and then pyelonephritis. So pyelonephritis is the most severe of all of these UTIs, and it's really the thing that we are trying to prevent. Okay, a bladder infection and certainly asymptomatic bacteriuria don't really have a huge impact on the pregnancy, but pyelonephritis can be a big, big problem. So the symptoms of pyelonephritis, these women are going to be very, very, very sick. They're going to be very sick feeling, and they're going to be very sick appearing. With acute cystitis, bladder infection, they won't feel good. They're going to have pain when they urinate, but they're not going to look sick. Women with pyelonephritis look sick. Anyone with pyelonephritis looks sick. And the reason is that this is a systemic infection. Acute cystitis is localized to the bladder, but pyelonephritis is a systemic infection. So the symptoms include malaise, fatigue, chills, anorexia, indicative of a systemic infection, and they may have symptoms of acute cystitis as well. This is affecting the bladder and then ascending up to the kidneys. Physical exam will usually reveal CVA tenderness, flank tenderness, and of course they'll appear ill. Diagnosis, you'll certainly want to get a urinalysis and culture, especially with that CVA tenderness and flank tenderness. You want to get a blood culture. Anybody who looks septic should be getting a blood culture. You want to get a CBC to look for signs of infection, and you'll want to get a metabolic profile. You'll typically want to get a metabolic profile on anybody you think is really sick, because you want to look for electrolyte disturbances. The treatment is admission and IV antibiotics. Of course, these patients are really sick. They're going to need to be admitted. And they need IV antibiotics because that's going to help with this more severe systemic infection. Oral antibiotics are good for bladder infections and stuff like that that can be treated on an outpatient basis. But these patients are really sick, and the IV antibiotics will just get there faster. Okay, so admission and IV antibiotics. Another important thing is to control nausea. So one of the symptoms that come with pyelonephritis is nausea and vomiting. I didn't include that up here, but it is one of the symptoms, nausea and vomiting. And we want to control the nausea because we certainly don't want her to be vomiting, because women with pyelonephritis, anybody with pyelonephritis, is usually going to be dehydrated, often from vomiting. And that can be a huge problem, because if the woman is dehydrated, that's going to put the fetus at risk. So we want to try to control that. So control the nausea. You can give something like doxylamine. You can give something, I suppose, like Benadryl, but typically doxylamine is given in pregnancy. You want, and this is important, so most of these women are going to be dehydrated, but there's a problem with this. Because of this systemic inflammatory response, they're going to be at risk for acute respiratory distress syndrome, pulmonary edema. So you need to be very careful not to go too far with replenishing their fluids. So that's why we want to control the nausea first, and then judiciously replenish their fluids with IV normal saline. Okay, so control nausea and normal saline, but be very careful. Okay, be very, very careful, and make sure that you're monitoring their pulse oximetry and all that stuff. Okay, so, but admission and IV antibiotics. Pyelonephritis is treated inpatient. So for antibiotics, you have a couple choices. You can do a second or third generation cephalosporin. One that jumps to mind right away would be something like Rocephin, ceftriaxone. That would be pretty common. Another regimen that you could give, especially in more complicated cases, would be Amp-Gent. And this has really, really good broad spectrum coverage. Amp-Gent is given a lot in the hospital, especially for patients who are very sick. because it's just got really good broad spectrum coverage. So either or, it really doesn't matter. You're not going to be asked between the two of these on the test. Cephalosporin or ampicillin gentamicin. You can transition these patients onto oral antibiotics after 24 to 48 hours as long as they're afebrile. So once they become afebrile, continue giving the IV antibiotics. After a day or two, you can transition them to oral antibiotics, and then typically then they can be discharged. Now, for this reason, you're not going to be giving them antipyretics. Okay, you're only going to give antipyretics if the temperature is really high. If their fever is really high, like over 103, 104, then you can give them antipyretics. Because in that case, then we're worried about the fetus. But we don't want to give antipyretics. We prefer not to give antipyretics because we want to see the resolution of their infection. And the first sign of resolution of infection is going to be that their fever goes away. So you'll want to watch their fever, and once their fever is gone for a couple days, then you can transition them to oral antibiotics. And then they will be on suppression therapy for the remainder of their pregnancy. So they're going to complete a couple weeks of their antibiotics, even after you transition them to oral antibiotics. But then they need to be on suppression therapy, and that can be just something like nitrofurantoin. For the nausea, you can give doxylamine, and often we give the doxylamine with B12. Doxylamine is just the generic of Unisom, but it's good for nausea. And then we usually combine that with B12. The combination of these two, there's a brand name for it, and the name escapes me at the moment, but these two together work really good for nausea and pregnancy. There's other things, though, that you can give for nausea, but this is one that I see most commonly used. Complications of pyelonephritis include SIRS, systemic inflammatory response syndrome, ARDS, which can lead to pulmonary edema and lung injury, renal dysfunction, usually from the dehydration, septic shock, which can cause hypoxic fetal events, spontaneous abortion, preterm delivery, that's a big one, and then intrauterine growth retardation and low birth weight infant. So just to recap here, asymptomatic bacteriuria, you're going to have a positive urine culture but no symptoms. Acute cystitis, you're going to have urgency, frequency, and burning, but other than that, no real symptoms. Urine culture, of course, will be positive. Urinalysis will show positive nitrates, esterase, increased white blood cells, etc., etc. Pyelonephritis, these patients look really, really sick. They may have urgency, frequency, and burning, but they're certainly going to have fever, CVA tenderness. They're going to look really ill. If you get a urine culture, it's going to come back positive. So all women are screened with a urine culture at their first prenatal visit and during the third trimester. We're looking for asymptomatic bacteriuria. Those women who do have ASB and acute cystitis will be treated with oral antibiotics, followed by a repeat culture, which comes after treatment. If there are 2 or more episodes after treatment with ASB, that's going to necessitate daily suppression therapy. Women with predisposing conditions like diabetes mellitus may get suppression therapy after the first episode of acute cystitis. Women with pyelonephritis should be admitted and treated with IV antibiotics until afebrile. Then they're going to be put on daily suppression therapy after finishing their antibiotic course for the pyelonephritis. And as mentioned, suppression therapy would be something like nitrofurantoin given every day, or you could use cephalexin. Major complications of pyelonephritis include ARDS, sepsis, renal dysfunction, as well as spontaneous abortion, preterm delivery, intrauterine growth retardation, and small baby. And that is all I've got for you for UTI and pregnancy. If you have any questions, write me a note below. Otherwise, I will see you next time.